Welcome back, everyone. I would now like to introduce Maria Thomas, who will be presenting on care, not punishment, rejecting carceral logics as a part of anti-racist practice. As a reminder, throughout this presentation, you can enter any questions you have in the chat. Maria Thomas is a community organizer and activist who works with various grassroots collectives on issues of racial and social justice, the violence of carceral systems, their impact on communities, and public health. She is also the director of child advocacy at Michigan Medicine. Over the years, she has held a variety of jobs, including teaching theater and dance to middle schoolers, painting murals for nonprofits, and working at a shelter/rehabilitation center for homeless women with mental illness, all in South India, and partnering with Harlem Children's Zone to run a youth mentoring program in New York. Prior to moving to Michigan Medicine, she also worked with the United Nations Children's Fund in India to create a documentary on HIV/AIDS and its impact on adolescent health. Her work over the last decade and a half has spanned healthcare systems, grassroots collectives, global health organizations, and arts and theater organizations, all in the service of building stronger and freer communities. It is my pleasure to introduce Maria Thomas.
Thank you so much. My name is Maria Thomas, as was just mentioned. I use she, her pronouns, and I'm a brown-skinned, light-skinned South Asian woman. I have jet black curly hair that is just a little above my shoulders. I'm wearing gold crescent-shaped earrings and sitting in a room with purple walls. Behind me is a beautiful snake plant. And there's also, I don't know if you can see it, but a poster of 3 organizers with the word justice written on it. First of all, before starting the presentation, I just want to express my deep appreciation and gratitude to all of the speakers, all of the organizers, and to everyone who is in attendance today for making the time to be here to have this conversation about anti-racism and how we can incorporate it into our daily practices and our work. I'm grateful for your presence, and I'm grateful that we get to have this conversation together. So the topic that I will be focusing on is care, not punishment. And I just want to provide a visual description of the poster on my opening slide, which is a beautiful piece of artwork by Chicago-based artist Molly Costello. And on it, she has a picture of these figures trying to uproot something with deep roots. And the language says, we are having to unlearn generations of teachings that taught us how to dehumanize and encouraged us to prioritize punishment. Next slide. So before getting into the content of the presentation, I just want to offer some brief definitions to ground us. And the first one is around what we mean when we say carceral logics or carceral logic. So this essentially refers to the punishment mindset that has crept into every government function, even those removed from prisons. And this punishment mindset permeates our bodies, our minds, our actions, all due to the fact that punishment is so ingrained in the dominant culture. And the second definition is from a public health collective called the End Police Violence Collective. And they define carceral systems, or the carceral system, as this extensive interconnecting network that is beyond just imprisonment policing, prisons and jails, but we're talking about immigration and juvenile detention centers. We're talking about the whole apparatus of courts, of probation and parole programs, immigration enforcement agencies, and other types of incarceration and confinement that happens in other places. Confinement in schools, in hospitals, involuntary confinement, electronic shackling in homes, or e-carceration as well. So that was just to do some level setting around shared definitions. And the other bit of level setting that I wanted to do, and JMAG did such a powerful job of setting the history and historicizing the context that we find ourselves in today. But the next slide also points at this long, long history that medicine has of pathologizing, criminalizing, and punishing marginalized populations, specifically Black populations in this country, but also other kinds of immigrant populations. So these are some works that have been highly influential in my own thinking. The work of Rana Hogarth, Liat Ben Moshe, and Jonathan Metzl. And the point I'm trying to make here is that there has been a long history of providers and medical professionals. Again, J. Mag talked about phrenology and J. Marion Sims, but there has been a long history of scientific racism being used as an excuse and a rationale to subjugate entire populations. We think about the fact that drapetomania was pathologized. This is when enslaved folks tried to run to their freedom, that was pathologized as some sort of a mental illness. We also think about the Black Power movement and how that was pathologized as schizophrenic. Talila Lewis, who is a disability justice practitioner who I've learned a lot from, talks about how this curative model that claims that some people are somehow deficient and need to be fixed draws a direct line from the medical industrial complex to the prison industrial complex. This idea that cures, treatments, and punishments are all so tied together. And then I also want to just briefly touch on how disability is criminalized. Liat Ben Moshe talks about how even after deinstitutionalization, we think about the history of psychiatric asylums and sanatoriums, which were carceral institutions. Even after deinstitutionalization, when those facilities were closed down, what we see is the lot of policing and incarceration aspects of these asylums were then exported to a lot of different treatments and services offered to folks in the disability community. And we see that happening today. And hopefully, through the course of conversation, we'll get to dig into that a little bit more. But those are just a few ways in which medicine and medical professionals have, in some cases, done that work of pathologizing and criminalization and punishing. And Jana mentioned in her opening that, the present is always with us. History is still something very real that we feel in our bodies, in the neighborhoods we live in every aspect of our lives. And so I want to talk about that continuing legacy. And so Lauren, if you could go to the next slide. We just cannot talk about anti-racism and racism without talking about mass incarceration. And more specifically, we cannot talk about it without talking about mass criminalization. And I really appreciate Teresa for bringing that framing up, right? It is criminalization, not just incarceration, but the ways in which medicine sometimes, and public health as well, criminalizes populations through the diagnoses they provide. So this is just to give you a horrific scale of how widespread incarceration is in the millions of people it impacts. The United States only has 4% of the world's population, but 25% of the world's incarcerated population. We're talking about 113 million adults who have an immediate family member who has been in prison. We're talking about 2.3 million people incarcerated in jails or prisons today. And that doesn't even account for the millions more who are in some form of confinement or incarceration, if you think about incarceration and other forms of surveillance and policing. Next slide. But this is a point that I want to underscore because it relates to this idea of how carceral logics creeps into medical spaces and public healthcare spaces, which is we're not just talking about incarceration. We are talking about a crisis of criminalization. So medicine and these carceral systems are not separate because this mindset, this punishment mindset permeates all over. And incarceration really represents a tip of a much larger iceberg, which is this growing crisis of criminalization. And I just want to say here, there's a difference between laws that criminalize and sort of things that are legally criminal. Legality is no indication or indicator of morality. Like I said, drapetomania was criminalized. Folks who are indigenous to this land are criminalized because they don't have certain kinds of paperwork sometimes. There's a difference between harm and crime. And all things that are harmful are not always criminalized. And things that are criminal or criminalized aren't always harmful. Again, if we think about how power structures have criminalized certain kinds of groups that they wanted to exercise social control over. I know that I just threw a lot at you in terms of like harms, crimes, right? But I'll try to make it real with an example. You think about Standing Rock. Not all harms are criminalized, not all crimes are harmful. When toxic oil pipelines were laid that pollute the land and water and displace and uproot communities, lives, livelihoods, those actions are not criminalized, yet the people who stood up rejecting this horrific assault on their land and their history were criminalized. And there are so many examples like that. Things that have been criminalized in public health and medical care, HIV criminalization, we think about marijuana criminalization, the war on drugs, all of these things were criminalized. They're now being decriminalized. And so we have to question and interrogate which things are being criminalized and how are we as a profession, given our sites, given the places that we occupy, feeding people into carceral systems, and we have to interrupt that criminalization. So, I mean, Andrea Ritchie and Beth Ritchie have written so much about this need to interrupt criminalization. On to the next slide. All right, so I've been talking for a fair bit just to set us up, and I'm really grateful that I get to talk about actions and strategies and things we can do, because I think it's easy to feel demobilized when just faced with the heaviness of this work, but there are so many things we can do. But to launch us into that discussion, I'd like for us to take a minute to, if you could just share in the chat box, examples and ways in which you see criminalization and carceral logic show up in your practice, or maybe not even in your practice, in your profession, in the health system, the clinic that you work for. And these are just some examples to kind of get your minds working. It could be around good and bad patient narratives. It could be about non-compliance, which, like Dr. Chilani and JMAG said, right, there are certain perceived non-compliance things that are so racially inflected. Absolutely. Being a mandated reporter, DHS reports. Yep. Terminating patients. We have more school officers. Yes, my goodness. I'm just reading the chat comments, which just signal to me how aware and how much you kind of see this happening, and maybe a thirst that things could be different, right? So Dr. Chilani mentioned the child welfare system. And I think about the fact that 1 in 2 Black children before the age of 18 will be under investigation or referred to CPS. And that is just horrific. When over 90% of the cases will be unsubstantiated, it is a system of control, surveillance, and criminalization. JMAG referenced Dorothy Roberts, whose work is just essential reading when it comes to the family regulation system, or CPS. Black people are drug seekers, right? There's this pathologization. In fact, just today I received a text from a dear colleague who talked about the case of Anna Brown. I'm going to see if I can pull it up real quick. Yeah. Anna Brown, say her name, was a St. Louis woman who was seeking medical attention due to her pain in her legs, which was deep vein thrombosis, in the emergency room at St. Louis University Hospital. And she died in police custody soon after she was denied treatment. Because the police at the hospital were heard saying that Ms. Brown was a drug seeker. So this, even during the perinatal period, there's this intense surveillance and intense scrutiny of all kinds of behaviors that are then used to label folks as a certain thing and refuse them treatment that they need, the support that they need, instead criminalizing them. Criticizing patient choice. I want to take time reading through all of these, but I'm just going to read a few out, knowing that I won't be able to cover all of it. But this is incredible and so insightful. Suicidal patient taken away from his parents to be transported to the emergency room for clinic. Police present to chaperone. Yes, so many things that we know about best practices in healthcare are thrown out the window. Informed consent, patient health information, right? PHI. When police accompany patients to the trauma bay and you're shouting out all of this personal information, we need to be able to have a protective, confidential space and provide the best care for our patients. And that cannot happen with police presence there, which is a recent development, mind you. Stigmatizing research on Black and Latinx children. Again, this exploitative, extractive mode of research that doesn't center the needs and doesn't remunerate and doesn't have like a more visionary liberatory research ethic. Black children medicated for ADHD, blanket diagnoses based on behavior. Yes, I think it was Teresa who mentioned conduct disorder and defiance disorder, all of which become excuses to criminalize, especially Black youth as they come of age where they can be sort of shunted into these carceral systems. All right. Thank you for sharing so honestly of your experiences and thinking so deeply about these issues. And I think what perhaps is a more empowering frame to think about is every instance that you've shared is an opportunity for interrupting that criminalization, especially when we do it in an organized way together. Can we go to the next slide, Lauren? Right. So I feel like a lot of the things that participants have already shared, you've already covered many of the things that are on this slide, but I'll just talk through a few more examples. I'm sorry about that interruption. A few more examples of how criminalization and carceral logic show up in healthcare today. So for example, we think about the recent Texas law, the SB 8, which just comes as a long history of criminalizing bodily autonomy and reproductive decisions, specifically for Black, Indigenous, migrant folks and pregnant people with low incomes, disabled, queer, and trans folks. This is not one kind of atypical or exceptional case. It is part of a web of criminalization, and it comes as part of a long history of criminalization. When that period of pregnancy leaves people fearful of accessing care if they use drugs and don't have supports. In fact, we know so many cases where pregnant people will experience stillbirths or neonatal mortality, often alone without care because they fear criminalization. People who use drugs, I think Teresa mentioned it in the chat, right? There's also typifying certain groups as drug seekers. And there's so much medically unnecessary drug testing, and we know that is racially profiled. We know that certain groups get tested and not others. I mentioned the example of folks who are criminalized for fraudulent ID, even in medical care spaces, being denied care, or having ICE called on them and being incarcerated as a result of a medical encounter. We think about how disability is criminalized in so many ways when security or the cops are called on people with mental health needs, but it's not just mental health needs, it's also different kinds of developmental disabilities, all of which are criminalized. I want to also lift up the example of sex workers for whom that medical care encounter can be a deeply traumatic one. In fact, if you're familiar with the work of Shira Hassan from Just Practice, they did this incredible research project, the Young Women's Empowerment Project in Chicago, a member-based social justice organizing project that is led by and for young people of color who have former experience or current experience in the sex trade and street economies. Shira and the folks from the Young Women's Empowerment Project did a survey of their members. And what they found out was that when they asked the question, where do you experience the greatest amount of harm, healthcare and police were neck and neck. In fact, respondents said that they felt they got the least amount of harm from clients or individuals that people typically think of causing the most harm and that we spend the most time and money prosecuting. They were seen as causing the least amount of harm, but that healthcare encounter and police who are supposed to protect or provide care, in the case of healthcare, that was the origin and the source of the greatest harm for folks who traded sex. Even from this year, there was a Michigan Harm Reduction Conference. I don't know if any of you were part of it or joined it, but this was something that Michigan Department of Health and Human Services had in August. And they had a whole session on underground and street economies. And there were so many testimonials from sex workers who talked about never feeling safe with medical professionals or disclosing their sex work or drug behaviors, even when they were off everything, because they were terrified that they would be judged as undeserving of care. And then I think, we've talked about police presence in hospitals. And I'm not going to spend too much time on the next couple of slides, but there are so many examples of how this relatively recent phenomenon of police presence in hospitals leads to this active criminalization. We know that law enforcement presence leads to increased provider bias. There are so many studies that show that those being treated with cops in the room are treated worse by providers. There are fewer tests drawn, attitudes actively change, and there's more stigmatization. And again, we see as sort of inevitable things that are true of today, but the truth is there was a time when there weren't cops in hospitals. And just like the movement to remove school resource officers from schools, which they weren't always in, which again actively funnels people through the school to prison pipeline, we can imagine a different way of providing care. Next slide. Because the truth of the matter is that cops in hospitals is just antithetical to medical ethics, patient-centered care, and healing. There's a resource at the end of my slide deck which has tips and tools for protecting patient privacy, especially as it relates to this question, that I hope you will find useful. Next slide. And again, like I said, the carceral system is not just about local law enforcement. We're also talking about the greatest the numbers of CBP far outweigh the number of law enforcement officers in other domestic police forces. And we see the horrific outcomes of putting money into those carceral systems when you have children detained by Border Patrol after emergency surgery. Next slide. So I know that I've been on a bit of a soapbox about how these carceral systems are so omnipresent, they're so pervasive, and how they need to be uprooted. And I don't want you to just take my word for it. This is the work that I do in my organizing, is to organize against the harms of carceral systems in community with loved ones who are inside the clutches of these systems. But I am not alone in recognizing the deep harms these systems cause. What do the public experts have to say? What do the public health experts have to say? The American Public Health Association, which, as you know, is the largest public health association in the country of something like 25,000 professionals who are part of it, a member association, unequivocally, in their October 2021 statement on advancing public health interventions to address the harms of the carceral system, they unequivocally say that we need to move towards the abolition of carceral systems and build in their stead just and equitable structures that advance the public's health. by decarceration, by divesting from these modes of punishment, and actually investing in the societal determinants of health, and by committing to non-carceral measures for accountability, safety, and well-being. So I just wanted to provide that background of there is a sea change. There is an increased understanding that public health and criminalization are at cross purposes with each other. And what I invite you all to do is to envision and think about ways in which we can provide care that doesn't rely on these harmful systems to address harm in our communities. Because we know that violence cannot remedy violence. It just displaces or dislocates the violence or harm in our communities to behind bars. Next slide. All right, so that was a lot. And this is where we move into the action. But if folks can just share like a word about how you're feeling. Are you still with me? How's everyone doing? And then we'll move into some tips, right, on what we can do, right? Which is why we're here. Okay, great. Thank you. I appreciate the interaction. All right. So what do? We have all of this information. We have this history. We have all of the amazing speakers who provided this incredible grounding, but let's move to action. The first thing that we need to do, now that we have APHA's clarion call to action, how do we move that to what we can do? And we start with the stories we tell. It's so important to ground ourselves in what we're fighting for and to set empowering regenerative frames for ourselves. So on the left-hand side, you have, and this is from the Berkeley Media Studies group, you have a portrait frame, which is about the individual. Portrait stories are things that tell us a lot about the individual, but doesn't tell us a lot about what surrounds them. And then you have a positive, wide, affirmative landscape frame. And that takes into account the social ecological model. It takes into account the environment around the person, the systems and the structures that surround them that shrink or expand their life choices and their life chances. And so the first thing that I would ask all of you who are at different stages in your journey of this anti-racist is a verb, thank you, Dr. Chulani, at different stages in that wake, woke, and work spectrum, is to think about the stories we tell and the frames we use, because frames are those mental pathways through which we understand and shape our world. And what I mean by having an affirmative frame and not just a landscape frame is that we need to ground ourselves in our shared values and our dreams and our goals, and not just have a reactionary myth-busting kind of frame. So for example, as a marginalized individual, it isn't always helpful to keep reacting and saying things like, not all immigrants are terrorists, which is absolutely true, right? But if we're always kind of reacting to a frame that someone else sets, we're not grounding ourselves in our own self-worth, in our own power. And the thing is, not only is myth-busting kind of bad for your own health if you're from a marginalized group, to always be sort of fact-checking others, and it's exhausting, right? But it's also not very good communication strategy. What we need to do is set affirming frames that center our worth is non-negotiable, that center human rights and Black humanity and the humanity of all marginalized and discriminated against folks as non-negotiable, right? And if we start and if we lead with these affirming stories and our values of safety, of community, of justice, that allows us to invite more people in. Sometimes if we start at the policy level, we lose people, but if we talk about like what it is we're fighting for, what's the frame we're talking about, that allows us to have a more clear vision of how we all band together to do this work. Values are therapeutic, and it is so important to ground ourselves in what we're fighting for. So that's just one reminder, in addition to all of the other incredible advice that you've gotten from previous panelists about rest being radical and other ways to intervene. So that's tip number one, is to frame in a landscape affirming way. Tip number two Next slide, sorry. Is to name. And this is a theme that we've actually seen throughout the presentations of today, from Jana talking about James Baldwin and the need to sort of name things, to JMAG, to everyone has talked about, we need to say what it is we're seeing. And so this is Solma Sharif, who's an Iranian American poet. She says, let it matter what we call and simplicity, upholding. So for example, examples of how we do this naming, right? Why is Todd still here? Todd needs to go. But there are other things like at the small p and the big P policy levels that we can be naming, that we can be fighting against, and that we can be refusing to accept. So for example, if your institution requires records that have no relevance to a person's ability to do a job, right? That practice needs to be uprooted. Like, so there's all of these efforts to ban the box, for example. If your institution invests in things that are displacing communities, if your institution is gentrifying entire neighborhoods and being extractive for the folks, from the folks who are being displaced, we need to name that and make restitution for that. If your institution, if your larger institution, for example, is investing in fossil fuels that is accelerating climate catastrophe, if your institution or your small practice is not paying a living wage to folks, like those are all things we can name and push back against. And we have to take risks in naming those things. And we have to take risks in knowing that, as Sarah Ahmed sometimes says, often we are named a problem because we named a problem, but we still have to name it if we care about anti-racist action. And the good thing is, if we do this naming collectively, there's less chance for retaliation. And so building power with each other is one way we can have a united front in doing this naming. Next slide. All right. So of course, we can't stop with just the naming and the framing to achieve anti-racism and achieve health equity, because research alone doesn't magically lead to changed policy. We have a mountain of research, and that documented evidence has not helped shape policy and practice the way it should. As Pakistani writer Aisha Siddiqui says, you all keep coming to a gunfight with infographics, and that is just not how change happens. And so the third tip is to analyze and map power. And so I'm really curious to see Vinny's resource on levers of power, because I think this is absolutely key if we are to enact anti-racist change in the places that we are, is we have to have a really good and solid power analysis. And we have to map the power, understanding who has it, how we organize against it, how we build power. And that has to include a sense of history and of structures. Because if we don't center and analyze the history and the root causes, the solutions that we come up with bereft of any analysis of power and history will fall short every time. And so again, we can build power by organizing together, building allies, disrupting harm, protesting, naming, proposing policies and changes. There are so many things that we can do. And the next slide is about the importance of action. I think it's easy to feel overwhelmed by all of these structures and systems, but our actions collectively and the choices that we make do add up to a force. Next slide. Organizing works, right? If we take collective action, it doesn't have to be huge. I think Jana mentioned AMB, Adrienne Marie Brown, who talked about small is all, even if it is just a couple of folks in your area that you know you have aligned values with, focusing on a very specific thing that is tangible. That's all it takes. It's finding people who are doing the work. It's supporting existing work. It's forming containers where you can join together around values and where you can agitate for certain kinds of change. But taking collective action is something that is hugely powerful. And there's so many types of action at so many different levels that you can do, from small p policy to big P policy to different practices. There's this Alice Walker quote that I really love, which is, we give so much power away by thinking we don't have any. And so I will say this, just as there is a history of scientific racism and folks within the profession who use science and medicine to subjugate populations, there is also an alternative history of resistance, of interrupting harm, of interrupting criminalization. You think about whistleblower Dawn Wooten. You think about so many people in this long storied history who have recognized and stood up against injustice and charted a way forward to a more caring, more affirming and more life-giving way of providing care. So these are just like a couple of examples, one of them from students at U of M who, thanks to their organizing, were able to reinstate STI coverage and testing coverage after the university said they weren't going to cover it anymore. But again, launching a petition, organizing against that, was able to create change that, had it not been for those student organizers raising their voices, wouldn't have happened. On the right, you have doctors for camp closures, protesting outside an ICE camp, demanding that folks be freed, that children be freed, and that those within confinement be vaccinated so there are no more flu deaths. This was after a spate of deaths in those congregate, cramped quarters of confinement. There is power in numbers, and taking collective action is hugely powerful. And I think that brings us to the last tip, which is to imagine. Just like Teresa talked about how joy is essential to this work and to sustaining it, so is imagination. And justice, as Dr. Ruha Benjamin reminds us, entails crafting and imagining the worlds we cannot live without, just as we dismantle the ones we cannot live within. And so that's almost near the end of my presentation. There's another slide, I think, with this beautiful art piece by Micah Bazant that says, "Imagine and rise." And I just want to leave you all with this quote, which is, well, before I launch into the quote, I'll just set it up. Oftentimes when we organize, when we take bold action, when we name things, when we stir up good trouble, when we imagine and demand, we're told, oh, that's not realistic. You're moving too fast, right? You need to slow your roll. You need to be reasonable. You need to compromise. And anti-racism is not about advocating for gradual change. It is about bold action, demanding the equality that everyone deserves. And so this is a quote by Stephen Salaita. And he says, "Ignore or correct anybody who tells you that demanding equality is unrealistic. Realistic and unrealistic aren't neutral concepts. Realistic means amenable to the status quo. Unrealistic means disagreeable to those who benefit from injustice." I'll just say that again. Imagine and be bold, and don't listen to people who say that you're being unrealistic, because, start quote, "Ignore or correct anybody who tells you that demanding equality is unrealistic. Realistic and unrealistic are not neutral concepts. Realistic means amenable to the status quo, and unrealistic means disagreeable to those who benefit from injustice." And I think with that, we move to my concluding slide, which is just a reminder to start with that positive frame and to change the stories we tell about ourselves and each other and the world, because that's going to influence how we act. I invite you all to name things as you see them, to map the power, so not bring infographics to a gunfight, to take that collective action, to find your people to take that collective action with, and to imagine and rise. And just thank you all for joining us today, for your time, for your attention, which I don't take for granted, and a lot of appreciation to you all. Thank you. Oh, Lisa, Sarah Ahmed says, when we name a problem, we're named a problem.
Thank you so much, Maria, for your enthusiasm and presenting these actionable strategies. It was amazing. We're going to dive into the Q&A now. So I have a few questions for you. First is, which pieces of your work are most misunderstood?
Which pieces of work is misunderstood? Okay, so I think thinking back to that APHA statement about the abolition of carceral systems and the need to bring something that is more equitable and just and more oriented towards liberation into the frame. Oftentimes when people hear that phrase of abolition of carceral systems, they think, well, what about this harmful group, or what about that harmful group? Like you will often hear sometimes good faith, but sometimes bad faith arguments about how that just isn't realistic. And I think one thing that is misunderstood about the work of moving to more restorative systems is the sense that, well, you know, folks who are advocating for that don't really care about violence. And the truth is that folks who are advocating for moving towards more restorative systems absolutely do care about violence, which is why we're advocating for these alternative systems, because violence cannot remedy violence. You cannot use one harmful system to uproot harms that are happening in community. And it's often survivors, queer folks, folks on the margins for whom these carceral systems have never afforded any kind of protection and who will never think of calling cops or institutions that have been the source of so many types of harm to them. They are the ones, we are the ones who are advocating for another way. So I think that's one example that I'd share.
Thank you. And many people are asking if you would share the author again of the quote that you spoke to at the end.
Sure. Yep. I can drop it in the chat.
Thank you.
And I'll just say one more thing about the question about misunderstanding, which I think, again, puts things into context. And this is a quote by a restorative justice practitioner called Daniel Sered. And she talks about how nobody enters violence for the first time through committing it. Nobody enters violence for the first time through committing it. So even when we see harms in the community, it is because of deep, vast, violent structural disinvestment in communities who are stripped of their resources, who are not given any life-giving, life-affirming resources to live their full, thriving lives. All they're offered are these criminalizing systems. So we need to sort of divest from these systems of harm and invest in the social determinants of health and invest in communities.
Absolutely. What do you wish healthcare providers knew earlier in their careers about racism and its impact on adolescent health?
Right. What do I wish healthcare providers knew about racism and the impact on adolescent health? Again, my frame is very much in how criminalization enters this space. And JMAG really powerfully illustrated those different points about linked lives and you know, those five points about the ways in which this shows up. And that thing about linked lives is something that I find so compelling, which is, we think about ACEs, adverse childhood events, things that happen to adults in your life affect children and adolescents. Messages that you get that are reinforced by media, by providers, all of that impact your sense of self. So again, I think it goes back to that landscape frame of understanding that, especially for Black folks, right? Seeing the harms of criminalization and police violence in your neighborhood on TV, that has a somatic effect that non-Black people of color and white folks are largely exempt from. So just understanding these things that may not affect you as a provider, especially if you're from an identity with intersecting privileges, just understanding how your reality is quite literally embodied differently, and doing that work to understand the history and the current reality of how resources and opportunities are distributed inequitably, but also harms are distributed so differentially. And just having that analysis is, I think, essential to providing good care.
Thank you. Can you offer a concrete example of the portrait versus landscape framing?
Sure. So one example is, say, a patient I'm making this up, okay? But if a patient shows up in your practice and you only see them as their diagnoses, right? That is a portrait frame. Or they may be trying to take care of themselves as best as they can. In the case of disability justice, they may be self-medicating to manage certain conditions that they have, right? A landscape frame would help us understand why that's the case and what systems of care they're being shut out from that leads them to those kinds of decisions. And a landscape frame would agitate to provide more resources for them. But instead, what we see is behaviors being criminalized without any supports being given. Also think about this in the case of the LGBTQ+ community, specifically around gender affirming care. The state often denies certain kinds of care. There's so much gatekeeping. And then folks who try to self-manage care through silicone injections is especially true in communities of color, trans communities of color. They are criminalized for trying to manage their care in the best way they can, given the absence of care for their communities. And so a landscape frame just takes into account all of the structures and systems that lead to certain things and actually advocates for more resources that addresses structural issues rather than just trying to excise from the community and that entire environment, the individual, and just see it as their problem or their bad choice or their decision. I hope that's helpful.